Okay, welcome everyone to today's session. So my name is Ben Adam. I'm a pathologist, a renal pathologist at the University of Alberta in Edmonton, Canada. And I'm joined by my co-moderator, Dr. Kammi Henriksen from the University of Chicago. And I'd like to welcome everyone to this fifth and final installment of the Renal Pathology Patient Webinar Series, with the focus of today's session being on the performance and adequacy of renal biopsies. So as a reminder for those that may be tuning into this series for the first time, the Renal Pathology Society is a nonprofit organization committed to the improvement and dissemination of knowledge regarding the pathology and pathophysiology of kidney disease. The RPS promotes excellence in diagnosis, fosters basic clinical and translational research, encourages training and education in renal disease, sponsors international conferences and symposia, and brings news and updates pertaining to renal pathology to its members around the world. So the goal of this patient webinar series is to further support interactions between pathologists and patients with kidney disease by providing patient-centered educational content focusing on the basics of renal pathology and common kidney diseases. So through this series, the RPS hopes to empower patients and pathologists alike, and thus work towards minimizing the burden of kidney disease around the world. So I'd like to acknowledge that this series is supported by an educational grant from Travere Therapeutics, and we are very grateful for their support. So just a couple of quick housekeeping items before I introduce today's speaker. If you have any questions during the presentation, please enter them into the chat function of Zoom, and we should have lots of time at the end to address them all. And then after the session, all attendees should be receiving an invitation to complete a short SurveyMonkey poll, which will just help us collect your feedback and improve future RPS webinars. So please watch your emails for that. Okay, so without further ado, it is my great pleasure to introduce today's speaker, Dr. David Howell, who will be giving today's webinar titled Performance and Adequacy of Renal Biopsies. Dr. Howell received his BA and PhD in microbiology and immunology and his MD degrees from Duke University. He remained at Duke, where he completed his residency training and fellowship in immunopathology in the Department of Pathology. Dr. Howell joined the faculty in the Department of Pathology at Duke in 1988 and was appointed professor in 2006. From 1999 to 2012, he served as chief of the pathology and lab medicine service at the Durham Veterans Affairs Medical Center. And in 2015, he was interim chair of the Department of Pathology at Duke, where he is now senior vice chair. His diagnostic and research interests are in the areas of renal, transplant, and ultrastructural pathology. He served as president of the Society for Ultrastructural Pathology from 2010 to 2012. He is currently a counselor of the Renal Pathology Society, and he is scheduled to become its president in 2024. He's the author of more than 130 journal articles and book chapters, and is a well-regarded speaker around the world. So yeah, without further ado, thank you very much, Dr. Howell, for joining us today, and I will hand it over to you.
Dr. Adam, thank you for that kind introduction, and many thanks to Ben and Kammi and the RPS Education Committee for inviting me to give this talk, and to the folks at Travere Therapeutics for supporting the entire series. I don't have any conflicts of interest to disclose. I will tell you in passing that I did give another version of this talk to the group at Travere several months ago, and I am very grateful to them for their interest and their support and their constructive feedback. The talk will be in 4 segments. The first of them is just to discuss natural limitations of percutaneous renal biopsies and why sometimes they may be even inadequate for diagnostic purposes. So particularly for any patients who might be logged on to the talk, I want to get us all the same page and give a little bit of a review of the morphology of the glomerulus. As renal pathologists, we're called on to diagnose glomerular diseases very frequently. So this is a cartoon of a slice of a glomerulus. Blood enters through the afferent arteriole shown here, and this branches into a plexus of specialized capillaries. These capillaries have 3 layers. The inner lining is an endothelial cell, which has specialized pores or fenestrae in its cytoplasm, shown here. The outer surface is lined by foot processes elaborated from a visceral epithelial cell or podocyte, shown here. And these interdigitating foot processes have a little structure called a slit diaphragm in between them. And then both of these cells rest upon a basement membrane, which is the thing shown in the crosshatch here. The capillaries hang on a network of cells called mesangial cells that have a matrix, the mesangial matrix around them. Now, if this thing is working properly, this trilaminar structure or filtration apparatus allows small molecules like water and salts and small nitrogenous wastes like urea to pass from the capillary lumen into the urinary space, but it holds back larger molecules like proteins in the circulation. So the glomerular filtrate accumulates out here in Bowman's space. This is Bowman's capsule. Bowman's capsule is lined by a simple squamous epithelial layer called the parietal epithelium. And then at the end, the capillaries recoalesce and blood exits the glomerulus through the efferent arteriole. So those are the players. This is what it actually looks like at very high magnification in an electron microscope. And I'll talk a little bit more about electron microscopy as the talk goes on. But we can see a lot of the structures that I pointed out in the cartoon. This dark stuff here is chromatin in the nucleus of an endothelial cell. This is a capillary lumen. This is the cytoplasm of the endothelial cell, and you can actually see the little fenestrae or holes in the endothelium. This is the basement membrane. This is the nucleus of the podocyte or visceral epithelial cell. This is its cytoplasm, and these little things that look like clothespins on a line are its foot processes. And if you look closely, you can actually see a slit diaphragm between these two podocyte foot processes. There's another one there. And this is a mesangial area. This stuff is mesangial cell cytoplasm. This is the mesangial matrix material surrounding the cell. And the nucleus of the cell would be somewhere off the picture to the right here. So glomeruli are present in the outer portion of the kidney or cortex. That's this light brown stuff here and an actual cross-section of a kidney. Deeper to that is the medulla, and the medulla doesn't contain any glomeruli. So if you want to analyze glomerular disease, you have to get a sample that includes renal cortex. And here's another cartoon of the same cross-section of kidney and sort of a stylized biopsy device that has been placed through the surface of the patient's skin and into the kidney, and it's gone through cortex and into medulla here. Now, you would think that if you're pushing sort of a trocar into the kidney, it has to go through the cortex, and so any biopsy that was taken in this way would automatically contain cortical tissue, good for diagnosing glomerular diseases. The trouble is the biopsy devices in use today don't work that way. They're more complicated than that. So here's a diagram. This is actually from a digestive publication. I don't think this thing was originally supposed to be a kidney, but let's suspend disbelief for a moment and assume that this clear area out here is cortex and the stippled thing is medulla. The biopsy device actually has two concentric layers. There's an inner needle, and right outside of that, there's a sheath. The needle has a very sharp, occluded tip. So this thing gets pushed through the body wall up to the surface of the organ. In this case, the person doing the biopsy has pushed it a little bit too far, and the tip is actually resting at the corticomedullary junction. And at this stage, no biopsy tissue has been procured. The person doing the biopsy presses a trigger on the device, and two things happen in rapid succession. The first of those is that this needle springs into the tissue. And the needle portion has a little groove in it that's about 2 centimeters long. The tip goes through the tissue and pushes it aside, but it's spongy and it rapidly springs back, prolapses into the groove in the needle. And then very rapidly, the outer portion or sheath is advanced over the needle, and it shears off the tissue that has prolapsed into this groove, enclosing it all, and then the whole thing is pulled out. So in this case, since the tip went into the corticomedullary junction, the sample that's procured is entirely medulla, which might be useful for diagnosing certain diseases, but is absolutely not useful for diagnosing glomerular diseases. Now, here's an image of what a core of renal tissue that actually contains glomeruli and cortex looks like. This is the cortical portion. Down here, I think we're getting into medulla. And you can actually see glomeruli sort of pooched out on the surface of this biopsy as little domes. And this thing would be about 1 millimeter in diameter, sometimes less if a smaller bore needle is used, and about generally 2 centimeters in length. So it's a very small, scarce, precious resource. Okay, that's the basics of a percutaneous renal biopsy, getting this little small piece of tissue to examine. And we'll talk about how we do that in a few moments. It's been my observation and the anecdotal observation of a lot of nephropathologists that over the years, the size and quality of renal biopsies has been progressively decreasing. And I think there's several reasons for this. First of these is concern, logical and viable concern on the part of the people doing the biopsies for patient safety. And this has led the people doing the biopsies to use smaller bore needles, sometimes an 18 gauge needle rather than a 16 gauge needle. And the larger the number, the smaller the diameter of the needle. And also to do fewer biopsy passes, take fewer cores of tissue with each biopsy. So the notion here with the smaller bore needle is that the needle might go through something like an artery. If you use a smaller needle, it's easier for the hole in the artery to heal, and you get less chance of significant hemorrhage. If you do fewer biopsy passes, your chance of hitting an artery is less. So we get skinnier biopsies, fewer biopsy cores. And then an important consideration is that over the years, more and more renal biopsies are being done by interventional radiologists rather than nephrologists. And these folks are very skilled at what they do, but they have some handicaps when they're doing a renal biopsy. First of these is they may not have complete clinical context on the patient. They may have been told this patient has proteinuria and we're doing a biopsy to evaluate proteinuria, but they may not know that the patient has chronic kidney disease, which can lead to marked thinning of the cortex, which makes it much easier to punch through with a needle, resulting in an all medulla biopsy. So they may not know upfront what they're dealing with the patient. Sometimes on the other end, they don't see the final report. So if they get a biopsy that's all medulla with no cortex, they may not know that unless I call them up and say, Bob, that biopsy didn't have any cortex in it. So the loop doesn't get closed sometimes. Another potential problem is that nephrologists, when they're doing biopsies, pretty much only do biopsies of kidneys. But interventional radiologists often biopsy a bunch of different organs, the liver, for example, that have a more homogeneous parenchyma. So if you're doing a percutaneous liver biopsy, it doesn't really matter whether the tip of the needle starts at the very surface of the liver or starts 1 centimeter in. It's all liver tissue and it all looks about the same. Very different situation for the kidney. And somebody does 10 liver biopsies for every 1 kidney biopsy. They may not be thinking that they need to get just the outer surface of the kidney to get an ideal biopsy. There are some patient-specific limitations to renal biopsies. Some of the patients who get biopsies are seriously ill. They may have difficulty cooperating with the biopsy process. They may have abnormalities in coagulation that lead the person doing the biopsy to only take a single core of tissue. As I've mentioned a couple of times, patients with chronic kidney disease often have a very thin cortex that it's easy to poke through and not sample with the biopsy. On the other end, we're having an increasing epidemic of obesity, and it's very hard to take a long needle and stick it through a large, thick body wall with a lot of adipose tissue and accurately get just to the surface of the kidney and not go too far, or alternatively not go far enough and not get a good sample. And then once you get one of these little samples that's only ideally 1 millimeter in diameter, and sometimes smaller if it's done with a real skinny needle, it's easy to crush them when you try to manipulate them. It's easy to lose track of parts of the biopsy if you aren't very careful. So a lot of reasons for limited specimens. What I'm telling you there is sort of anecdotal and conjectural, but there is an evidence base that's beginning to build on this. This is a paper from the group at Oregon Health and Science University, including several members of the Renal Pathology Society. that compared biopsies done by interventional radiologists and nephrologists. And they found that radiologists actually tended to get a little bit more tissue across the board, but the biopsies that the nephrologists did had a greater percentage of cortex. And the level of inadequacy for nephrologist biopsies was lower, about 1%, than for radiologists, which was a little more than 5%. There have also been studies that do document that more and more biopsies are being done by radiologists than nephrologists. And this is from the group at Rush University Medical Center, showing that over the years, there's been a transition to performance of percutaneous renal biopsies from nephrologists to interventional radiologists. So you have more biopsies being done by interventional radiologists. The quality of their biopsies may be a little less than from nephrologists. So overall, maybe the quality of biopsies has a reason for going down over the years. Now, this is not to say that radiologists don't think critically about what they're doing. And this is a paper from a couple of years ago from a group in Saskatchewan. And this is a group of radiologists, and they look very carefully at parameters like the angle of the needle relative to the surface of the kidney, the so-called angle of attack, whether the biopsies were aimed at the renal poles or mid-portion of the kidney, and whether a conscious effort was made to avoid medulla on the ultrasound. And they found that an angle of attack of about 60 degrees was optimal. And if they did that, aimed for the poles and tried to avoid the medulla, they had fewer inadequate biopsies, and there's a collateral benefit of having fewer bleeding complications. They said something very astute at the end of this discussion, which is that if there were special circumstances for what was needed for diagnosis, there was a need to have good communication between the nephrologist, the pathologist, and the radiologist. I think this is immensely insightful of them. This is actually a group of radiologists saying you really need to talk with your nephrology and pathology colleagues around the time of the biopsy. That may be the most important teaching point in this entire lecture. It makes me sort of want to move to Saskatoon and work with these people. So what if you get a limited specimen? Well, sort of one of the worst things is that you just may not be able to make a diagnosis at all. The diagnosis line says tissue insufficient for diagnosis. You get a little bit more tissue. Sometimes you can make a diagnosis, but it's limited or incomplete. There are several ways that a diagnosis can be incomplete. It can be vague. So you may say, well, I can tell that this patient has glomerulonephritis, but I can't tell you what kind it is. Patients frequently have more than one thing going on in their biopsy, and sometimes you get one diagnosis, but particularly if the sample is limited, you can miss a second diagnosis. And finally, you may not be able to provide accessory information, particularly how much active disease is present and how much chronic disease is present. So active disease, necrosis, crescent formation, inflammation, chronic disease, sclerosis and fibrosis, things that might not be amenable to any kind of therapy. So you can say this patient has lupus nephritis, let's say, but you can't say how much active and chronic disease is present. So sometimes this is at least as important as being able to put a name on the disease. Finally, sort of worst case scenario is that with a limited biopsy, you may stretch too far trying to make a diagnosis and come up with a diagnosis that's simply wrong. This is a little short list of diseases that are especially vulnerable to undersampling and particularly hard to analyze in a small biopsy. So intimal arteritis in transplant biopsies can be very focal and easy to miss on a limited tissue sample. Infectious processes and tumors are often very focal. Parenthetically, there is an infection in renal transplants caused by BK polyomavirus that tends to center mostly or preferentially in the medulla rather than the cortex, although you can also see it in cortex. So a sample that's got a lot of medulla is really good for diagnosing polyomavirus-associated nephropathy. Focal glomerulonephritis, particularly pauci-immune glomerulonephritis associated with anti-neutrophil cytoplasmic antibodies. Patients with an early pauci-immune glomerulonephritis may only have involvement in one of 20 or 30 glomeruli. So if you have a sample that's only got 5, it's very easy to miss it. Focal segmental glomerulosclerosis is another disease that early on in its manifestations can be very, very focal. Okay, so we got this little limited piece of tissue, and things get more complicated, particularly for renal biopsies, because ideally we like to do 3 different forms of microscopy in analyzing them. We perform light microscopy to look at the overall tissue architecture. We perform immunofluorescence microscopy for staining of immunoglobulin and complement components to look for things like immune complexes and anti-basement membrane antibodies. And then we do electron microscopy to look at the fine structure and distribution of the deposits, plus a whole raft of other things like damage to endothelial cells, epithelial cells, and basement membranes. And unfortunately, each of these 3 studies requires tissue that has been fixed and processed in an entirely different manner. So light microscopy is done on tissue fixed in an aldehyde fixative, formalin, and embedded in paraffin wax. Immunofluorescence in its usual way of operation requires fresh frozen tissue without a fixative. And EM uses another aldehyde fixative, glutaraldehyde, and the tissue is embedded in an epoxy resin. It makes a very, very hard block that's necessary for cutting the ultra-thin sections that are needed for EM. So you need to divide your biopsy into 3 different aliquots for these 3 different studies. And if you're looking for glomerular disease, you have to make sure there are glomeruli in each piece. There are 3 basic ways of doing this, and sort of one of the most basic that's done in some centers, particularly if there's not a nephrologist around, is to simply take a separate core of tissue for each of the 3 studies. And in these cartoons, the glomeruli are the little red blobs, so that's cortex, and that's medulla down here. And these are good cores that have mostly cortex and a little bit of medulla. Now, you can do it this way, but there's some drawbacks. One of them is that even with a skilled operator, sometimes 1 or more of these cores doesn't have any glomeruli in it. It's all medulla, and that study gets shortchanged. As I mentioned before, a lot of clinicians don't want to take 3 cores in the first place and would be skittish about doing this. And then a final thing for the EM cognoscenti is that a whole core is usually too much tissue for electron microscopy. So I said this core is about 2 centimeters in length, and an electron microscopy block can only accommodate maybe up to a 2 millimeter core of tissue. So if you have a 2 centimeter core to start with, this has to be put in about 10 blocks. Each of those has to be processed and examined, at least at the light microscopic level, separately. So that's a whole lot of work for somebody. Second way of doing this, assuming you get a couple of cores, actually you can do this with 1 core as well, is to blindly, without the aid of a microscope, cut off the tips, 1 millimeter or 2 of each end of each core, put them in glutaraldehyde for electron microscopy, and then divide the rest of the tissue, again, blindly, for light microscopy, a little bit more for that, and immunofluorescence, a little bit less. The idea here is that if you have a core of tissue that contains cortex and medulla, sort of topographically speaking, at least 1 end has to have cortex. So again, this is okay, but it doesn't allow direct visualization of cortex and medulla, so you're doing it blindly. And this is still kind of a lot of tissue for EM. If you got 2 cores, you end up with 4 EM blocks. And that's still a good bit for the EM lab to work with, although it's better than 10. So really the best solution is to actually examine the cores under a microscope, ideally with something called a dissecting microscope, and cut a piece for electron microscopy under direct visualization, so you know there are glomeruli there. Another piece, usually a little bit longer, for immunofluorescence, and the rest of the tissue for light microscopy. So you know exactly what you're doing here because you're looking at it. You get ideal proportions of the tissue pieces. So a lot of tissue for light microscopy to look for things like focal necrosis and an early pauciimmune glomerulonephritis. A sufficient amount of tissue for immunofluorescence, and then 1 little piece of tissue that's a good quality piece with glomeruli in it. So the EM lab ideally only has to do 1 block. And then finally, if you have enough people to do this, you can take this microscope to the patient bedside and look at the cores as they're coming out. And if they're all medulla, you can tell the person doing the biopsy, Bob, you got to go back and take another core. This is not going to be diagnostic. This is a picture of dissecting microscope, the tissue rests on a glass plate that has a light source underneath. And then we have a low power microscope that allows you to look at it at about 5 or 10x. And there's enough working room here that you can put a scalpel underneath and cut off pieces while you're looking at what you're doing. This is an example of what cortex looks like under an electron or a dissecting microscope. The glomeruli, I've shown you, are very vascular structures, and when the biopsy is taken, there will be blood in the glomerular capillary loops. And so the glomeruli show up as these little cherry red blobs. This, in contrast, is medulla. We see these long, straight vessels, but no glomeruli. So ideally, after we've done this, we're left with 3 little pots of tissue, very small pieces, but nonetheless pieces that each have glomeruli in them, processed for the 3 basic studies. So once we've got those 3 small pieces of tissue, we try to squeeze as much information out of them as possible. So the first thing we can do is use a single tissue block for more than one study. And I'll concentrate here for the moment on the paraffin block that's a portion for light microscopy. So there are a whole bunch of things we can do with this. Hematoxylin and eosin stains cell nuclei blue, and pretty much everything else mostly red or pink. And this is our sort of basic go-to stain for just about any kind of biopsy, not just kidney, but anything in surgical pathology. We can do other histochemical stains for things like carbohydrates and basement membranes and fibrous tissue. And I'll show you some examples of 1 or 2 of those. We can do immunohistochemistry. And the typical way of doing this is to take antibodies against either normal tissue components or things that shouldn't be there, like viral proteins. Antibodies are conjugated with an enzyme system that catalyzes the production of a colored precipitate from a colorless substrate. And so you see little patches of color where the antibody has localized. There's a sort of a kissing cousin to that called chromogenic in situ hybridization, where the probe, rather than an antibody, is a stretch of DNA that binds to DNA or RNA with specific sequences in the tissue, like nucleic acids of a virus that might be in the tissue. We can do molecular diagnostic studies. You can take tissue from the paraffin block, deparaffinize it, dissolve it, and get nucleic acids like, let's say, DNA, and look for things like immunoglobulin gene rearrangements. So you'll get clonal rearrangements of immunoglobulin genes in B-cell lymphomas. And this is a powerful way of diagnosing a B-cell lymphoma. You can do tests for other nucleic acid sequences. There's a thing called short tandem repeats, which are little repeated sequences in the DNA that differ from person to person. This can be done for identity testing. It's actually used for paternity testing in our clinical laboratory. But you can do it in tissue, and it's not particularly useful for native renal biopsies, but can be very useful for transplant biopsies, where let's say you have a tumor that's arisen in a kidney transplant, and you want to know whether the tumor arose from donor tissue or from infiltrating recipient cells. We don't do this very often, but it's a very powerful technique when we do it. And then finally, you can do other types of molecular tests. So you can dissolve tissue from paraffin sections, make protein peptides from it, run it through a mass spectrometer, and figure out, let's say, what kind of proteins are present in amyloid deposits. So amyloid is a fibrillary protein that deposits in pathological conditions, and different kinds of amyloid can have, at last count, at least a couple of dozen different kinds of fibril proteins in them. So mass spectrometry can be used to distinguish all of those. All of that just on a little paraffin block with a 1 millimeter piece of tissue in it. We'll illustrate with a case. This was a 55-year-old guy who had had a renal transplant about 3 months previously. His serum creatinine had gone up rather alarmingly. And he had cytomegalovirus circulating in his bloodstream, which led to the supposition that he might have a cytomegalovirus renal infection. So here's his biopsy at low power, and this is this hematoxylin and eosin or H&E stain. And we have cortex here, a couple of glomeruli, tubules. They're back to back without much in between them. This actually looks kind of normal at this magnification. And you wander into this really bad zone here where something very different is going on. We can see this at a little bit higher power over here. There's hemorrhage. This pinkish stuff is necrosis. And remember, on the H&E stain, nuclei stain blue. So there's too many nuclei here. This could theoretically just be an inflammatory infiltrate. It could be a very focal form of transplant rejection, but it's sort of an odd pattern for that. We worry that it might be something else. And indeed, when we look at much higher power, you see a lot of these cells have very big irregular nuclei. It's very easy to see nucleoli in a lot of them. Here's a kind of a funny looking mitosis. This cell is dividing. There's another sort of misshapen mitosis. Another one there. There's a lot of cell division here, a little bit of necrosis here. So this doesn't really look like a garden variety inflammatory infiltrate, but how do we prove this? Well, if it's just inflammation, it should be mostly T cells. And CD3 is a marker for T cells. And we've done immunohistochemistry here, and the brown precipitate is where the T cells are. And there are some T cells here, but the vast majority of these cells are B cells, and CD20 and PAX5 are markers for B cells. And so there's maybe 10 times as many B cells as T cells. That makes you really suspicious that this is some sort of a lymphoma. And PAX5 is a nuclear regulatory transcription factor that's selectively expressed by B cells. This not only tells us that these things are B cells, but it shows us something about the shape and size of their nuclei. A lot of them are very big and irregular. The clincher here is this chromogenic in situ hybridization test. So this is in situ hybridization for an early RNA of something called Epstein-Barr virus, the so-called Eber-Sisch test. And this red precipitate means that these cells are transfected by Epstein-Barr virus. This is characteristic of something called post-transplant lymphoproliferative disorder. And in fact, this patient had sort of a bad version of it called diffuse large B-cell lymphoma type. So this is really an aggressive lymphoma. That's not the end of the case. Keep it in the back of your mind because we're going to return to it in a few minutes. So what we've done on this is the H&E stain, some other histochemical stains that I haven't shown you, but I'll show you one in a minute. Immunohistochemistry for T cells and B cells, and chromogenic in situ hybridization for Epstein-Barr virus. A lot of things from a little tiny piece of tissue. The second thing you can do is use a single section of tissue for more than one stain. So getting double duty out of one slide. You can do multi-ligand immunohistochemistry, the sort of technique that I showed you in the last couple of slides. You can also do multi-ligand immunofluorescence microscopy, where you use antibodies that have been tagged with different fluorescent dyes that have different colors. This allows conservation of limited tissue specimen. You can see two or more ligands in context, and there may be a little bit of saving for technologist time because they only have to stain half as many slides. Now, I'll show you one example of this with a two-color immunofluorescence stain. So these are tissue sections that have been stained with antibodies against two different alpha chains of type 4 collagen. The red antibody is against the alpha 2 chain, and this is a form of type 4 collagen that's an important constituent of a lot of different basement membranes. So in this tissue section, this is from a normal example, we see staining of tubular basement membranes, we see staining of the basement membrane of Bowman's capsule, and we can also see staining of the glomerular capillary loops. It's a little bit obscured here because they also stain with the second antibody. The green antibody here is against the alpha 5 chain of type 4 collagen. And this, along with the alpha 3 and 4 chains, makes what's called a heterotrimeric complex that's a very important and selective constituent of glomerular basement membranes. So we see the green here within the glomerular basement membranes with a nice linear pattern shown all over here as well. That's the way it's supposed to look. Now, the gene for the alpha 5 chain is on the X chromosome. And if you're a guy, you have one X chromosome. And if the alpha 5 gene has a mutation that keeps the alpha 5 protein from being made in the normal manner, the entire alpha 3, 4, 5 complex fails to form and deposit in the basement membrane. And you have what's called X-linked Alport syndrome. And this alpha 3, 4, 5 complex is very important for the basement membrane structure. So in these patients, you have a progressive degradation of the basement membrane structure over time. So this is a biopsy from a male patient with X-linked Alport syndrome. And you see the red staining for the alpha 2 chain, but there's absolutely no staining for the alpha 5 chain, no green. Things get a little bit more complicated with female patients. So female individuals have 2 X chromosomes, but early in embryonic development, one or the other one gets randomly inactivated. And so if you're a female heterozygote with one good gene for alpha-5 and one bad gene that doesn't allow production of the protein, you end up with little clones of cells growing up from these progenitor cells that have inactivated one or the other X chromosome. If they inactivate the bad chromosome and keep the good chromosome, you get normal expression of the alpha-5 chain, which is shown by the green signal here, and this female heterozygote for an alpha-5 mutation. If you inactivate the good chromosome and are left only with the bad gene for alpha-5, you can't make the alpha-5, and we have these areas where there's red but no green. So this person is a heterozygote that during embryonic development, there's a random inactivation, and some people are lucky and tend to inactivate more of the bad chromosome, and they often have no phenotypic effect and no evidence of renal disease. If you're unlucky and inactivate the good chromosome more often, you can have manifestations that are a lot like a male patient with X-linked Alport disorder. The final thing I want to talk about is repurposing of a tissue block. And I've shown you we have these 3 tissue samples. Now it's possible to thaw out the frozen tissue block that was a portion for immunofluorescence and either process it to paraffin for light microscopy or process it to epoxy for electron microscopy. That's been done in renal laboratories and indeed other laboratories for decades now. It's also possible to deparaffinize tissue from the paraffin block, postfix it in glutaraldehyde, and process it for electron microscopy. That's also been done for decades. And the EM on a specimen like this is not as good as fresh glutaraldehyde fixed epoxy embedded tissue, but you can often get pretty good inflammation from it. A more recent technique that's been developed in the last maybe 5 to 10 years is to take tissue sections from the paraffin block, deparaffinize them, treat them with heat and proteolytic digestion to open up the conformation of the proteins that have been cross-linked by the formalin, and then do immunofluorescence. So I'll illustrate with a case biopsy from a 20-year-old female who presented mostly with hematuria, but not much else going on in the workup. This is a low power view on an H&E stain. We see several glomeruli, cortex, maybe a little bit of interstitial fibrosis here, but this is kind of close to normal looking. The glomeruli look fairly well preserved. We look at one at higher magnification here. This is a mesangial area, and this mesangial area has got 5 nuclei. Now, normal mesangial region should only have 2 or at most 3 nuclei, maybe like that one. So we have mesangial hypercellularity. And here are a couple of our other histochemical stains. This is a PAS stain, or periodic acid shift stain, which is a carbohydrate stain. There's a lot of carbohydrates in renal tissue and things like glycoproteins. If there are immune complex deposits here, the heavy chains of antibody molecules are also glycosylated, and they'll show up as PAS positive. So these mesangial areas look a little bit expanded, and here's one that's got about 5 nuclei. So again, looks like something's going on in the mesangium. Here's a Jones silver stain. This is a basement membrane and matrix material stain. This is a capillary loop. Normal basement membranes in the capillaries have a thin, delicate appearance. They look homogeneous when they're cut en face, and that's indeed true here. So it doesn't look like there's anything going on in the capillary loops. This is pretty much a mesangial process. When we look by electron microscopy, there are indeed deposits here, and this is the characteristic appearance for an immune complex deposit in an electron microscopy of a renal biopsy, this darker granular stuff. Here's a red cell in a capillary loop, basement membrane, podocyte foot processes, fenestrated endothelium. That all looks normal. So this is a mesangial disorder with immune complex deposits. Trouble is, it could be any of a number of things. Lupus nephritis has mesangial forms, as we heard very nicely discussed in a previous talk in this series by Andrew Chang at Chicago. And so this could be mesangial lupus. It could be IgA nephropathy. So we really don't know. We need to do immunofluorescence to look at what proteins are deposited. Unfortunately, all the tissue that was apportioned for immunofluorescence was medulla, and we do an H&E stain of the frozen tissue so we can look at its architecture. And this is all medullary tissue. So at the time we got this biopsy, we didn't have immunofluorescence worked up on paraffin sections, but fortunately, we're about 10 miles down the road from the University of North Carolina, and UNC and Duke are intense rivals in basketball and football. But we are close collaborative friends in renal pathology, and Dr. Volker Nicolait, who had this test worked up, very kindly did it for us. We see polygonal staining of little clumped areas in the IgA stain, but no significant staining for IgG or IgM. You would have expected this if it were lupus nephritis. A little bit of staining for C3. And this pattern is diagnostic for IgA nephropathy. So that's one example of repurposing tissue from one block to another. I'm going to show you an extreme case here, and this goes back to our 55-year-old guy with the renal transplant. And as I showed you earlier, there's a part of the biopsy that looks fairly unremarkable, and then another part that's badly damaged, and we were able to establish that this stuff was post-transplant lymphoproliferative disorder. Now, unfortunately, in doing all those immunohistochemical and in situ hybridization stains, we entirely depleted the paraffin block. This biopsy came at a time when we weren't routinely putting up tissue for electron microscopy on renal transplant biopsies in the first few months post-transplant, although we started getting much more aggressive about doing that in the last few years. And unfortunately, the frozen block didn't have any glomeruli in it. So I'm getting a little ahead of myself. I told you this part looked relatively normal, but when we took a close look at the glomeruli, they were abnormal. Capillary loops look thickened on the H&E stain. And now here's the Jones silver stain. And instead of a nice smooth homogeneous basement membrane, there are all these little punctate holes. And that usually means that there are immune complexes embedded in the basement membrane. But as I said, we depleted the paraffin block, and we didn't have any tissue for electron microscopy, and there was nothing in the frozen block. So fortunately, our electron microscopy laboratory has a fantastic technique that allows you to peel a section of tissue off of a glass slide. And the way this is done is to take the cover slip off the slide, flood it with liquid epoxy resin, let it polymerize, and then peel it off with a razor blade and very carefully make sections of this and look at them in the electron microscope. This was pioneered by a tech in our lab, Henry Estrada, with the mentorship of Dr. Sarah Miller, who's the director of the laboratory and also my wife. And this is the electron micrograph that Henry got from this specimen. And it's not beautiful, but I would say arguably it gives you exactly the information you need. Here's the capillary lumen. Here's the urinary space. This is what's left of a nucleus. There's the basement membrane, and here are immune complex deposits with little spikes of basement membrane material growing up around them, synthesized by the podocyte. So in addition to post-transplant lymphoproliferative disease, this patient had membranous glomerulonephritis, diagnosed using repurposing of tissue from an H&E stain section for electron microscopy. Now, in the interest of full disclosure, once something is in an epoxy block, it's pretty much impossible to go back and do immunofluorescence on it. It's very hard to go back and do histochemical stains. There are a few labs that have tried this, but usually this is kind of a point of no return. Okay, so we've discussed a little bit the natural limitations of percutaneous renal biopsies, talked about possible reasons why they might be getting smaller and of lower quality over the years, talked about how they're divided up for different kinds of studies, and once they're divided, figuring out how to squeeze as much information as possible out of each piece. So how can we do better? Well, one possibility for getting better biopsies to begin with is to modify renal biopsy technique. And I think the paper that I showed you from the group in Saskatchewan, the radiologists who were studying very carefully the angle the needle needs to go in at, where to aim for, and so forth, is encouraging information that suggests people are thinking about this actively now. As that group suggested, better communication is key. So before the biopsy, if you have a patient with chronic kidney disease, and you're the nephrologist and a radiologist going to be doing the biopsy, call up the radiologist and say, this patient's got chronic kidney disease and probably has thin cortex. Please be very careful when you put in the needle. After the biopsy, if it's inadequate, call up the radiologist and say, I'm sorry, this was not adequate. And on the other hand, if it's a really good biopsy, call them up and say, wow, that's the best one I've gotten in the last couple of months. Please, whatever you did, do it exactly the same way the next time you do a biopsy. And then finally, as I mentioned in passing, real-time quality assurance during the biopsy, taking a dissecting microscope or even just a hand lens to the patient's bedside. This can be done by a pathologist or an extender like a pathologist's assistant or lab tech. But ideally, particularly if the biopsies are being done at a center where there isn't a nephropathologist, you could teach the nephrologist or the radiologist to do it themselves. We actually have a pediatric nephrologist who has bought his own dissecting microscope and looks at his specimens at the bedside to make sure they're okay. That's all I have to present. I want to make several acknowledgements for help with this work. First and foremost, I want to acknowledge our patients to whom this talk is focused and directed. The patients who provide us with biopsies that not only allow us to make diagnoses, but also to learn and get better with time. Again, the folks at Travere Therapeutics, particularly Kevin Fowler, who's a patient advocate who's been particularly passionate about trying to get nephropathologists and radiologists together to improve the process of biopsy. Clearly, as I've shown you a whole bunch of different studies, and this takes several different clinical laboratories to do all the different pieces. And Duke fortunately has wonderful examples of all of these laboratories. A lot of the pictures I showed you were done by two wonderful photography technologists, Susan Reeves and Steve Conlon. Our department is lucky enough to have a photography shop that gives us superb support. Clinical colleagues, pathology colleagues, and radiology colleagues, too numerous to count. And finally, I mentioned Dr. Sarah Miller, who's not only my collaborator. We published almost 20 papers together, for a long time, directed the EM laboratory that provided most of the pictures you saw, and is my wife, who has put up with me for, at last count, at least 36 years. So I'll stop now and be happy to entertain any questions.
All right, thank you so much, David. That was such a great overview, and I really enjoyed those case examples at the end. And I agree that the communication of sort of the degree of adequacy of the biopsy with the person that is performing it is so helpful to improve our techniques moving forward. So we've got a number of questions that have popped up here. So I'll sort of sort through these for you. There's a number of people asked about what is the ideal gauge of a biopsy needle recommended for adults and for pediatrics? Yeah, so
That's an excellent question. As a nepropathologist, ideally I like to have the largest bore needle that can be used safely. Typically, and ideally, a 16 gauge needle is good for adults. The inner diameter of an 18 gauge needle is about the same diameter as a pediatric an adult glomerulus. So if you use an 18 gauge needle, it's hard to fit a glomerulus into the width of the biopsy. A lot of them end up getting transected. Pediatric glomeruli are smaller, and in some cases, 18 gauge needles are considered customary and adequate for pediatric biopsies. Some of our people who do biopsies, including nephrologists, will occasionally use 18 gauge needles on adults. And frankly, we can sometimes get very good information from them. But I would say, ideally, 16 gauge for an adult, 18 gauge is okay for a pediatric patient. Back in the day, sometimes people used even a 14 gauge needle for renal biopsies. I haven't seen one of those used anytime in the recent past. They gave beautiful, big, fat cores of tissue, but they are not currently in use, as far as I know, for kidney biopsies.
Fantastic. The first question that popped up was from the earlier portion of the talk where you talked about kidney biopsy performance, and they were wondering, does high blood pressure limit options for kidney biopsy?
Yeah, and I would say the answer is yes, and I'm not a real subject matter expert on that part of the clinical end, but I certainly know that any number of times I will get advance notice from our nephrologist saying, I'm going to do a biopsy on Mr. Smith tomorrow. And then the next day rolls around, we don't get the biopsy, and they'll call us up and say, couldn't do the biopsy because the patient became hypertensive, and we have to take a couple of days to treat the hypertension and get it down. So there are impediments in terms of hypertension. There are impediments in terms of, oh, the patient said he took a bunch of aspirin yesterday. He didn't know he was supposed to stop doing that. They won't take the biopsy because they're afraid that that will potentiate bleeding. I don't know how many of these are absolute criteria. So I think sometimes patient's blood pressure is incompletely controlled, but sort of okay, they'll go ahead and do a biopsy. They might elect to take only a single core of tissue in a case like that to limit possible complications.
Parmjeet has a number of questions here regarding cortex versus medulla. So what percentage approximately of your biopsies have both cortex and medulla? What percentage have medulla only?
Yeah, great question. And I must say, I have not looked at this in a systematic manner, but I would say the vast majority of biopsies will have some of both. And that's really an ideal thing in many ways. There are some disease processes like focal segmental glomerulosclerosis that tend to start down near the corticomedullary junction. So you want to get some deep cortex grading into medulla. And then there are a few other things. I think I mentioned the polyomavirus associated nephropathy, where a lot of the action is often in the medulla. And some things like disorders where casts accumulate, like urate nephropathy and light chain cast nephropathy, sometimes have a disproportionate amount in the medulla. We are now at the initiation of Laura Barasoni, who joined our renal pathology faculty 2 or 3 years ago, starting to report out what percentage of the biopsy is cortex and what percentage is medulla. And I would say probably, I would estimate that 80% of biopsies contain cortex and medulla. Roughly 10 or 15% of them contain cortex only, usually a pretty good specimen. And probably something like 5% are only medulla. So our folks are pretty good at doing biopsies, and we tend to get fairly high quality samples. Now, one thing I forgot to mention when I showed the study about biopsy adequacy from the Oregon Health and Science University is that Patrick Walker at Arcana Laboratories has done a very large comprehensive study of biopsies Arcana gets from all over the country. And he has a more comprehensive data set that substantiates and expands the findings of the OHSU study. And I think his incidence of medulla-only biopsies may be a little bit greater. A lot of the biopsies that we see at our center are coming from Duke and a small number of referral labs that do a fair number of biopsies. Pat gets biopsies from smaller places that do a smaller number of biopsies. I think his medulla-only fraction is maybe a little bit higher. But for us, it's probably about 5%.
Okay. Parmjeet followed that up with, do you guys specifically ask the nephrologist or radiologist who are performing the biopsy to get medulla if the diagnosis of BK virus is suspected?
We haven't done that. It would probably be a good idea. As I say, probably 85 or 90% of our biopsies do contain some medulla. So we're usually okay with that. And in my experience, although the polyomavirus nephropathy is often preferentially seen in the deeper portions of the tissue, it's very frequently manifested in the cortex as well. So I have not taken the step of asking them to make sure they get plenty of medulla, but that would be a good idea. I'd be interested whether Parmjeet does that.
Yeah, I'd be curious about that too.
if he's still logged on.
Yeah, maybe he'll enter into the chat.
Okay.
A question about how swift is tissue transferred to fixative, and a follow-up with that, does the lag time in transfer of tissue into the formalin container alter the PAS stain? My technician complains of that often. Please clarify.
Yeah, that's a good question. And I don't know the specific answer. I can tell you that we attempt to get the tissue into fixatives as rapidly as possible. Back in the old days, nephrologists doing biopsies at the bedside would actually take a kit with the different fixatives, and they would divide the biopsy and put it into formalin or glutaraldehyde as rapidly as possible, sometimes within a matter of minutes. Now they're transported from the site of the biopsy to a lab that's in a different building, and it often takes a few hours for that to happen. Ideally, we try to fix them as fast as possible. I wouldn't have thought theoretically that a PAS stain would be susceptible to changes of lag and fixation. PAS has a very basic form of chemistry. So you have carbohydrates on proteins, glycosaminoglycans, glycogen, and the Schiff reagent forms an adduct, called a Schiff base with oxygen molecules on the carbohydrate, and it's a covalent bond. So the thing is very stable, and carbohydrates are usually pretty stable. I wouldn't have thought that a PAS stain would be particularly susceptible to degradation, but I must confess I'm not sure. I'd be welcome anybody else who's logged in who knows the answer to that question to respond. I wouldn't have thought that would have been the problem, but obviously it sounds like something's going on in your lab that needs to be investigated.
Right. Okay, so moving on. So everyone who's on the call, thank you for staying with us, and we're going to keep going because Dr. Howell does not have any obligation at noon Eastern time. So we will try to answer all the questions that are here. So next question is, do you recommend Michelle's for immunofluorescence? So
we've had very good success with Michelle's for immunofluorescence, and for our in-house biopsies, we attempt to fresh freeze them after they've been transported on a saline moistened gauze whenever we can, but occasionally they get taken over the weekend or very late in the evening when there isn't anybody staffing the lab that does the immunofluorescent staining. They have to go in Michelle's, and then all of the specimens we get as referral specimens from other institutions are fixed. Actually, Michelle's is not really a fixative per se. It's a solution that contains ammonium sulfate or something like that sort of reversibly curdles proteins and stabilizes them for up to a few days. Then you wash that out and they sort of spring back to the normal configuration. So all of our referral biopsies from elsewhere, and I suspect the vast majority of the stuff that Pat Walker and Chris Larson and colleagues at Arcana get, the piece for fluorescence comes in Michelle's transport medium. And the results we get with it are really very good. I haven't done a head-to-head comparison of that with fresh frozen tissue, but my impression is that there's not a substantial difference between the two. So I think you can feel safe using Michelle's transport medium and get good results from it. The one thing you want to make sure that you don't do is cross-contaminate the pieces that go into Michelle's solution with an aldehyde fixative, particularly glutaraldehyde, because these fixatives can mess up the structure of the antigenic ligands that the antibodies react with. And glutaraldehyde, if it binds to tissue, also causes this terrible autofluorescent glow in the fluorescence microscope that makes it almost impossible to interpret anything. So yeah, I'm all for Michelle's, and we've had very good results with it. Let's see.
You're muted, Kammi.
Yeah.
Sorry about that. Parmjeet had a comment just saying, great talk and thank you for sharing your experiences. And he said, regarding carrying dissecting microscopes to the bedside, a good alternative is to carry a compact Wi-Fi microscope that can easily be carried along in a small bag. So that's helpful.
Yeah, I absolutely agree. And I think some of our practitioners who do biopsies are starting to do this. I'm sort of I'm one of the old guys who started off 30 or 40 years ago, and I'm not as experienced with the new technologies, but Parmjeet is of about my era, and so I'm extraordinarily impressed that he has gotten with the new wave like that. That's an excellent idea.
All right. Thank you for the excellent talk. What's your experience about the ultrastructure of podocytes when tissue from paraffin or frozen blocks is salvaged? Great question.
My experience is, I would characterize as highly variable. We sometimes, so there's a couple of sort of linked questions here. One of them is, should you use tissue from the frozen block or the paraffin block? And each of those things has advantages and disadvantages. Tissue coming from the frozen block has been frozen before it hit any fixative, and this can cause disruption of the ultrastructure. But on the other hand, it hasn't been subjected to organic compounds like xylene that are used for paraffin processing. So the paraffin block has never been frozen, so it doesn't have the freezing artifact, but it has all sorts of disruptions, particularly to cell membranes, that are caused by xylene and stuff of that sort. So that's sort of I think they're kind of more or less of equal quality. I know Laura Barasoni prefers the frozen tissue block. I've traditionally preferred the paraffin block. I think you can get good results with either. And my observation has been that sometimes you take tissue from paraffin and you get beautiful results. It looks almost like something that's been fresh fixed in glutaraldehyde. The foot processes are easy to see. Every now and then it looks terrible. Some people have suggested to me that this may have to do with how hot the tissue got during paraffin processing. So I think you just have to, if you need the information, you have to try it. And if you get what looks like good ultrastructure, report it. If you get ultrastructure with a lot of artifactual change, do the best you can. And in the comment to your diagnosis, say, we think that there is foot process effacement and coarsening here, but the interpretation is limited by artifacts required or due to necessary paraffin retrieval of the tissue.
Right. Okay, so next question is, the repurposing of frozen tissue to routine processing generally gives poor morphologic details. Are there any specific procedures to improve the quality of H&E slides from the frozen tissue?
So I would say thaw it slowly, and if possible, thaw it into fixative. This can be, our laboratory actually uses gelatin to embed the specimens for immunofluorescence staining. So you have to warm them up and get the gelatin off before you fix them. But you want to get them into the fixative as rapidly as possible, and it's best to thaw them sort of gradually. Those are sort of the main tricks that our laboratory uses.
Okay. Okay, so I'm going to combine two questions here. So basically, how many glomeruli are needed to call an adequate renal biopsy sample? Does it vary for children and adults? And then Fadi says, do you apply the minimum criteria of 10 glomeruli to diseases like IgA nephropathy, lupus nephritis, all other diseases?
So to my knowledge, this is, at least for me, better standardized for transplant biopsies, where 10 is sort of an absolute cutoff. For the rest, it's sort of relative, and I must indicate and confess that I haven't made an absolute cutoff. What I will tend to do for something like evaluation of IgA nephropathy is try to give a MEST-C score, but then if it's a small biopsy, typically less than 10 is kind of a rough cutoff that I use, I'll make a comment saying that evaluation of the specimen is limited by the size of the biopsy with an aggregate sample of only 6 glomeruli in all of the studies, so that it's conceivable that this could be a higher grade or a different MEST score. So I try to give a diagnosis with a disclaimer. I will say one important thing to recognize that I didn't really mention, although I sort of mentioned it in passing, is that for all of the 3 studies, not only light microscopy, but also immunofluorescence and electron microscopy, we do a light microscopic stain and section to look at the tissue. I showed you an H&E stain on a frozen tissue block that didn't have any glomeruli. And we likewise look at our electron microscopy blocks using something called a semi-thin survey section stained with toluidine blue. And these things are good quality histologic sections. So you may have only 5 glomeruli in the paraffin block, but by the luck of the draw, you may have 5 more or even more than that in the electron microscopy block. And I try to synthesize the light microscopic findings from all 3 of those pieces of tissue in making an assessment of the adequacy of the biopsy. Every now and then you'll have a biopsy where the cardinal diagnostic finding, even if it's a light microscopic finding, is only in, let's say, the EM block. I've had a couple of cases of focal segmental glomerulosclerosis where there weren't any segmentally sclerotic glomeruli in the paraffin block, but they showed up only in the EM block. Made a diagnosis of renal sarcoid one time using only the electron microscopy block.
Oh. Okay. Thank you for this great experience of renal biopsies. Could you tell more about ECD donor renal biopsy, and especially, as to your opinion, how it differs from renal allograft biopsy?
I'm sorry, what was which kind of donor biopsy?
ECD donor renal biopsy.
ECD.
Yes.
Oh, extended criteria donors. Yeah.
Gotcha. Okay.
Yeah. Okay, so that's a whole nother area in which I wouldn't consider myself to be an expert. I would say, in general, our center is starting to see more extended criteria donors for kidneys, also sometimes for other things like livers. And for anybody on the call, I expect most of you are familiar with this paradigm. We're now using donors who 10 or 15 years ago would not have been considered for kidney donation. One of them is that the donor may have some mild underlying disease like hypertension or diabetes, or be an older person than the old cutoffs would have allowed. Sometimes they have underlying systemic viral diseases like hepatitis C, or even in some cases human immunodeficiency virus. So it's considered that these kidneys probably won't be in the best possible condition. And then another wrinkle of this is that donors in the old days had to have died by brain death. So the patient's declared brain dead, taken to the operating room, and organs are harvested while the heart is still beating and they're still being perfused. So they're perfused with good oxygenated blood right to the point when they're taken out and rinsed with a cold perfusate solution that slows down metabolism. Nowadays, we're seeing more donors with a situation that used to be called donation after cardiac death, and is now being called donation after circulatory death. The patient is in extremis on a ventilator, but is not brain dead. And the notion is that when the ventilator is stopped, the heart will stop beating. Patient is declared cardiac dead, and then taken to the operating room, and the organs are plucked out as rapidly as possible and perfused with the cold perfusate solution. Usually it takes 15 to 30 minutes for that to happen, maybe. And there's chance for the tissue to be injured during that time. So I can tell you that the approach to donor biopsy in extended criteria donors is that a donor biopsy is done much more routinely in them. So we're seeing more and more donor biopsies. You look for evidence of underlying disease processes. Unfortunately, some of the things that can happen in procurement of extended criteria donor organs don't really show up on a biopsy. So if there's been some ischemic damage that occurred right at the time of procurement, sometimes that will be invisible when the donor biopsy is done. But that's a complicated area. We typically get cortical wedge biopsies rather than needle biopsies of those donor organs, because the person who has procured the organ has it out there on the table and can take a cortical wedge. It's a sort of a plus minus situation. They tend to be larger pieces of tissue. They often have 100 or maybe even a couple of hundred glomeruli in them, but it's all surface tissue. And there tend to be chronic changes in things like hypertensive nephrosclerosis that concentrate at the surface of the kidney. And a surface cortical biopsy can overestimate those things. So I don't know if that really answered the question, but that's my brief experience with ECD biopsies.
Yeah, that was a great answer. All right, the next one is in the sample case in which your immunofluorescence was done on the paraffin embedded tissue, did you use any special technique for antigen retrieval like pronase digestion? Yeah,
so that one very kindly was done by Volker Nicolait, who is down the road at UNC and actually a past president of the Renal Pathology Society. He and Sharon Singh there have been wonderful about doing special techniques for us that their laboratory has worked up. This was, I'm pretty sure, because we're working up the technique now, is a mixture of heat-induced epitope retrieval and pronase digestion. I'm pretty sure that the enzyme we're using is pronase. And both proteolytic digestion and HIER, heat-induced epitope retrieval, are extraordinarily common techniques for paraffin enzyme immunohistochemistry, things like the CD3 and CD20 stains. This is an extension of them as a preparatory step for fluorescence. And usually for enzyme immunohistochemistry, you use one or the other, but I'm pretty sure that the techniques that are used for paraffin sections for fluorescence get sequentially treated with both of those things.
Paramjeet just wanted to note from our discussion earlier, we do not ask our clinicians to get medulla either. They would probably be very hesitant to do so even if we asked.
Yeah, and thank you, Paramjeet. That is one of the things that I sort of glossed over in the study from the group in Saskatchewan, is that since the medulla, it's very vascular and it's close to the big vascular structures and the hilum of the kidney. So one tends to get more bleeding if one specifically aims for the medulla. And that study had a greater complication rate for bleeding complications in the biopsies where the needle went into the medulla. So yeah, I would say usually I'd be happy with a biopsy that's got a little bit of medulla and a good bit of cortex. And usually I think we can do a pretty good job of diagnosing the polyomavirus infections.
Question about, can alcohol-based fixatives be used for immunofluorescence?
I don't know. And if anybody who's logged on knows the answer to that question, please let me know. I'm pretty sure that the sections we use for immunofluorescence, the frozen sections, get a little incubation with some form of alcohol, maybe ethanol, before they are stained, but I can't remember for sure. I don't know the answer to that question. The clinicians or the pathologists who use ethanol fixation most commonly in sort of general pathology are hematopathologists. And it's fairly common to fix a bone marrow biopsy in ethanol, but I don't have any experience using that for kidney biopsies.
Okay. Do you think the lack of on-site microscopic examination of the samples significantly influences the rate of inadequate samples?
I would say particularly in places where not a lot of them are being done, the answer to that would be yes. And I think Pat Walker's data set substantiates that. A lot of our practitioners here have gotten pretty good at looking at biopsy cores just sort of sitting out on a gauze. And if you're a little bit nearsighted and look at them very closely, you can often see the glomeruli as little blobs. You know, sometimes we'll up in the immunofluorescence laboratory, we'll get some cores out of the bottle and say, yeah, I know these are going to be good. I can see the little blobs there. So I think you can do a reasonably good job if you look at it carefully. It gets more difficult with a patient with chronic kidney disease, where it becomes harder to see the glomeruli even if you have a dissecting microscope. So the flip side of that question is that if you got somebody with fairly advanced CKD, even if you do have a dissecting microscope at the bedside, sometimes it can be hard. To be absolutely truthful, since our biopsy suites are a couple of blocks away in a different building from where I am, I don't usually go to the bedside with a microscope. Some of the people doing biopsies have their own microscopes or hand lenses or cell phones, as Parmjit said. And so at our center, we haven't made a systematic effort to implement this, but our biopsies are generally pretty good. I would say biopsies that are judged entirely inadequate here would be less than 5%, maybe closer to 1 or 2%.
Okay. A question about when do you actually use pronase digestion IF? I guess what are your indications for doing that?
Yeah, so this for IF is exclusively when we're trying to do the fluorescence panel that we would ordinarily do on frozen tissue, but on formalin fixed paraffin embedded sections. So in the immunofluorescence lab, it's used solely for that purpose. In the larger immunohistochemistry lab that does CD3 and CD20 and CMV stains and things like that, they use a wide variety of different enzymes. Pronase is one of them. I think trypsin is another one that's commonly used. Proteinase K is a third one. So that has a big use in routine enzyme immunohistochemistry. But for us, it's just on trying to retrieve tissue from paraffin blocks for fluorescence.
Okay. I did want to address Yael's thoughts here. She says, fabulous talk. Would love to have our trainees, IR colleagues, and immunopath lab techs hear it as well. And I agree with that for sure. So this is recorded and will be posted on the website, just so everyone knows. And please do share.
Yeah, and I would say parenthetically, I think one of Yael's chats said that she had to log off, but I should probably contact her. She gave us a wonderful Grand Rounds talk about quality assurance in pathology on our Grand Rounds series. Did it remotely via Zoom. And I would be delighted for her to have access to the recorded version, but I'll offer her to give it as a real live interactive talk if she wants it. Turnabout is fair play.
Exactly. She asked another question here, and I want to address it because I'm sure she will watch the recording. So what do you think about the value of bedside adequacy assessments by inexperienced providers during on-call hours? Is it better than no interprocedural assessment or not? So for instance, on-call techs, residents, non-renal faculty, et cetera. We have always trained them, but then wondered.
Yeah, that's a good question.
Good question.
And I would say if you can get a good one and train them well, I think they could be very helpful. But I would say that an inexperienced person can wander into all sorts of problems. The situation where I have more experience with this is evaluation of pre-implantation donor biopsies, which we talked about a little bit a few minutes ago. Because now when those come in the middle of the night, the current system is to have one of our senior residents come in, look at the biopsy, and share it via telepathology with an attending pathologist who's at home. And these people are, I would classify them sort of as inexperienced providers who are very bright people, but have had access to only a limited number of biopsies to look at them. And we've had some boo-boos with those. They sort of generally think that the main thing they have to look for is sclerotic glomeruli, and they'll miss vascular lesions, interstitial fibrosis. They will sometimes not see fibrin thrombi and capillary loops of a donor who has got a thrombotic process going on. Fortunately, that one is usually not a deal breaker because they generally resolve. Actually, way back at the beginning of my career, published a paper about how donor kidneys with thrombotic capillary loop thrombi tended to open up and do well after a week or two. But they'll sometimes miss those things. Actually had one where a resident on call didn't direct the attending pathologist to the appropriate glomeruli and missed a necrotizing glomerulonephritis with crescents in a donor biopsy that turned out probably to be associated with a Bartonella infection. Fortunately, the recipients of those kidneys ended up doing well. So sometimes it's sort of no harm, no foul. But yeah, I absolutely agree with Yael that sometimes somebody who has been incompletely trained can give you a false sense of security and make things worse rather than better.
Right. Here's one that hasn't come up yet. What are your feelings about endovascular renal biopsies?
So we don't have anyone who's practicing them here. The only case that I've ever seen, and I still haven't figured out anatomically how it might have happened, was a biopsy from somebody who was supposed to be getting a transjugular liver biopsy. And somehow they got the biopsy device down the wrong aperture and did an absolutely beautiful biopsy of kidney, including cortex. So they stuck it way out into the kidney. I do have more experience with transjugular liver biopsies because I used to practice liver transplant pathology a great deal of the time. Again, I'm sort of one of the old school renal pathologists like Parmjeet, who became a general transplant pathologist in addition to doing renal pathology. And the transjugular liver biopsies have actually gotten quite good. Sometimes we get big, substantial cores of liver tissue that look for all the world like they might be an 18-gauge needle percutaneous biopsy. So I think it is possible to do it well, but my only experience has been that one where they were trying to get to the liver and went down the wrong rabbit hole. And that was a beautiful biopsy on which I think I could have made very astute diagnoses.
Excellent presentation. What's your opinion about Buin as a fixative?
Have not used Buin, and I don't have an opinion and would encourage anybody else who's logged on who has used it to say. There are some alternative fixatives that some centers use. Karnofsky's fixative is sometimes used. And there's a mixture of formalin glutaraldehyde, and it supposedly gives good results. You can take a piece of tissue and fix it in that and use it equally well for EM or light microscopy paraffin sections. And I would say parenthetically that the electron microscopy cognoscenti will tell you that glutaraldehyde is the best fixative for electron microscopy. But actually formalin is a pretty good fixative for it as well. So sometimes centers referring biopsies in will send just a core of tissue and formalin with the notion that you can use that for both EM and light microscopy. And that actually works pretty darn well. And in some ways, it might be better because if they try to subdivide it at the source and they mess up and don't get any glomeruli in one of the two samples, it doesn't work out very well. If they send you one core of tissue in formalin, you can look at it under the dissecting microscope and see the glomeruli. It looks different from fresh tissue, but you can still see them, and you can cut off pieces for both studies that contain glomeruli. So I have a little bit of experience with alternative fixatives, but I have not used Boone's, and I don't have any evidence base with that.
Okay. And do you have any experience with snap freezing for immunofluorescence with liquid nitrogen?
So we have not done it that way. We're sort of fussy. We encase the biopsy pieces in gelatin, and then do sort of a slower controlled rate freeze, typically by taking a liquid nitrogen bath and immersing a dewar of isopentane and putting the biopsy into that, and it freezes at a slower rate. I have not used snap frozen tissue. My suspicion would be that the antigenicity would be just fine, but the structure would be a little bit harder to interpret. That you could still see binding for IgA and a granular pattern, but be a little bit harder to tell exactly where it is. So I think in a pinch, you could probably do that. We have occasionally done that for like a C4D stain. So we'll get a biopsy on which we're in the surgical pathology frozen section area, and the surgeons will take an intraoperative biopsy and say, I need to know whether this is viable or not, so I can decide whether to take it out. So we do a conventional operating room frozen section. And while the tissue is still frozen, we'll have the lab cut some extra sections, unstained sections on slides, send them over to the fluorescence lab. So that's often tissue that's been frozen in a much more offhand or snap freeze type way. It tends to work okay for a C4D stain. So I think you can do that, but it's for tissue architecture, it's not quite optimal.
Okay. I'm just going to go, we have a couple minutes left. I'm just going to ask one or two more questions that I had missed. How many cores do you usually receive for light microscopy? What's ideal?
So it depends on the center that's sending the tissue. We have one center where there's a group of radiologists who say the way we want to do it is to take one core for each study. So we get one for light, one for fluorescence, and one for EM. So that's a case where we get one. Ideally, we like to get at least two cores, usually two cores, and apportion some tissue for light microscopy from both of those cores. So the standards say for transplant biopsy adequacy, say that you need 10 glomeruli and 2 vessels for a true adequate sample. But there's a little rider to that says ideally the specimen should include either 2 cores or a long core that's got 2 different portions of cortex separated by some medulla. So this would be down at one of the poles where the needle has gone through cortex into medulla and out cortex on the other side. So since some of the disease processes we look at are very focal, I do like to have more than one core. So if we get the cores and divide them up in our laboratory, which is the way we do most of our in-house biopsies, I try to put pieces of both of the cores into the blocks for light microscopy. And a sort of an example of focality would be the PTLD that I showed. That is something that would have been very easy to miss with insufficient sampling. So I like to have 2 cores for light microscopy due to the focality of processes. I'm more comfortable having tissue from just 1 core for either electron microscopy or immunofluorescence, since the things that you see by those techniques tend to be fairly diffusely distributed. So one glomerulus is often as good as another glomerulus. Obviously, there are exceptions to that. Things like cryoglobulin deposits can be very focal. And if you get the wrong glomerulus for EM, you may miss them.
All right, well, we just clicked to 11:30, so I'm going to cut it off here. We got through almost every question, though. Dr. Howell, I just want to thank you so much for this incredibly informative talk and really thoughtful discussion, a very lively discussion. Those were great questions and great answers.
Kammi, thank you so much. And I'm likewise gratified by both the attendance and interest in this talk and the number of questions I got. I sort of looked at it just before I logged on and said, gee, I wonder if anybody is going to ask anything. And I don't think I've ever gotten this many questions. That's fantastic.
Right? That was over a half an hour of questions. That's amazing. So, so thank you so much for your time on behalf of all of the participants and the Renal Pathology Society. Very much appreciated.
Yeah, thank you, David, for the fantastic talk and for fielding all those questions. And thanks, Kammi, for moderating the discussion. And thanks once more to Travere Therapeutics for supporting this webinar series. So just as a reminder, as Kammi mentioned, the recording of this session will be available on the RPS website within the next week or so. And again, please watch your emails for the post-session survey to provide feedback. So yeah, thanks again, everyone, and we'll see you again at future RPS webinars.
Great, thank you so much.
I'm gonna go have a beer.
Have one for us.